Thank you so much for sharing your insights, Dr. Stephen, Dr. Adnan, Dr. Zara, and yeah, Dr. Azhar. So I think we'll just dive into Q&A now because we didn't have much time. First, we're going to discuss about the digital health infrastructure and integration. So I may start with Dr. Azhar. I think Dr. Azhar quite she wanted to go. She's catching an airplane, so that's why I would like to ask Dr. Azhar. There are some recent studies, even the one that you presented, indicates that the telehealth has really the potential to bridge the healthcare gaps. You know, especially in the low and also the middle income countries. So, given this context, how can these countries really effectively design and also implement the telehealth solutions that would cater the unique challenges and needs of their population? What do you think, Dr. Azhar?
I I think to effectively design or implement a telehealth solution, I would suggest implementing some form of design thinking.
Mm-hmm.
I believe we should not be creating an application or solution hoping that it would work and gain high usage. In design thinking principles, we are actually required to approach, we need to talk to and present the idea or prototype to a specific end users for their input and suggestion. And if you go through the process of design thinking, the process, there are 5 processes. Then we were able to understand the users or any group of population for that matter. We will understand better. And surprisingly, if you go through that process, we would be actually addressing certain assumptions that we never thought before. And we will actually need to gain insights into the real users' needs and what could be their challenges. For example, when we rolled out our cardiac health, we never thought of, we would be interfering with patients' day-to-day chores, or they were traveling to work or having to go to the post office and so on. And that was when that our healthcare worker were actually making that telecom consultation call, right? So that was really overlooked, right? So by going through that design thinking process and evaluating and then coming back to the drawing board, hoping that at the end of the day we would come out with something more applicable, more approachable for the patients or end users to use.
Yeah, but I noticed that the infrastructure, especially in the rural areas, still it remains a significant barrier to telehealth adoptions. So, are these like, for example, you're mentioning design thinking process, or do we have some successful case studies or models, maybe from other regions that we can have, that we can have leverage alternative for infrastructural solutions?
If we were to talk about infrastructural solutions or models, there are some reports in Africa and even in Australia that provides telehealth using some form of satellite for remote areas, and especially to cater for the aborigines. Now, those reports did show some positive results or outcome, particularly because of the stability of the connectivity.
True.
Now, when you have a stable connectivity, that would actually give good advantage for video conferencing, like what we have now. And in Australia, there is a culture whereby when there's, especially in the indigenous population, when you have an important decision to make, for example, the patient needs to undergo a major surgery and the families are scattered across different communities or geographical areas. So this did report by using satellite telecommunications and getting the family members together virtually, the decisions were able to be made quickly because it is a clinical decision. So the decisions were be able to make quickly, and actually to save time for having the trouble for families to travel afar from their homes to the hospitals in Australia. So that, I think that was a really good model, that something that we could apply.
Yeah, the accessibility, affordability, and the accommodation. Yeah. Thank you
Yes,
so
right.
much, Dr. Azar. I would like to go back to Dr. Stephen because studies showed that the human touch, in patient navigation can actually increase the trust up to 40%. That's what's in the previous study. So how might the integration of the digital health navigators can actually alter the perceptions and the utilization of the digital health platforms? Dr. Stephen, yeah.
Yep, thank you. So there are two factors in consideration. So factor number one is that the healthcare system, and by inference, the digital health ecosystems are notoriously difficult to navigate. Right?
Mhm.
Even for people who have well trained to a certain degree, in technology, they sometimes find it difficult to navigate. And one typical example is today I have a couple of visitors come to my office to discuss about digital health technology, and we have to connect a remote site for a demonstration. And for a room of people who are technically totally competent, we were struggling to connect. So we get video and then we don't get audio, and then we get audio back and then we don't get video. So navigating technology is actually very challenging. So therefore, having a navigator, a human navigator, to provide that hand holding and also the technical support will make it a lot more comfortable for people who, especially on the consumer end of the healthcare services, and less technically oriented. So that gives them the comfort, let them know that there are somebody there to walk by their side during their journey of learning and hold their hands if necessary, provide the technical support. And that's very important. The other things comes to the cyber security and also the trustworthiness of the information. Even if the consumer knows where to find the information, today there is a big question as to, am I able to trust the information at all that I am able to acquire, right? So AI is a blessing and also a curse in the sense that we know that there are so many deep fake type of information. And the biggest problem with deep fake is that if you mix 10% of false information with 90% of truth information, you can do significant damage, right, to a person who consume the digital health knowledge or information. So having a human navigator to help the person to say that, okay, well, if you are not certain about what you can trust, come to me. I can walk the journey with you and help you navigate the information and dissect what can be trusted, what can't be trusted. And so that gives people a lot of confidence. The same applies to the health navigator. Healthcare system is notoriously difficult and designed to be difficult. I think it's by design, right? To discourage use. And so therefore, people find it very alienating. Research has proven that a patient health navigator has tremendous impact on the patient's ability to navigate the system and to trust the system. So the same analogy apply to digital health human navigator, more so because of the difficulties in technology. As I said, even technical experts sometimes find it very challenging, and the deep fake knowledge out there that I can't understand why somebody would want to do that, but welcome to the real world. People do that, and so therefore it makes it very, very difficult for some people who actually trying to sort of understand the information, let alone have to worry about that some of them may be false. And having that human sort of navigator does sort of at least help in those two aspects.
That could be one of the reason, you know, maybe of the less adoption of telemedicine in Malaysia, as what Dr. Azhar mentioned. So yeah, the human touch, you know, of the patient.
Telemedicine has another added dimension of difficulties. Now, you and I are clinicians, although I'm a retired clinician. We know that sort of clinical medical practice sort of rely on more than just seeing you across the screen. You need to be able to touch, you need to be able to auscultate, you need to be able to sort of like palpate, you need to be able to do all sorts of physical examination. Now, using telemedicine works only if you have another healthcare provider at the other end being guided by a specialist. And so therefore, I worked with telemedicines for many years ago, when in Melbourne, the St. Vincent's Hospital, where I have a connection with, they have a cardiology telemedicine program where they have patients sort of in the rural area. Their pre-surgical clinic is being done remotely by telemedicine. So they have a cardiologist and cardiac surgeon sitting at the specialty hospital end. And then they have the patients sort of like primary care provider at the rural end, in a secondary or community care hospitals, and guide the doctors at the other end work through the pre-admission clinic type of routine, and that works beautifully. So there are a lot of conditions that needs to be satisfied for sort of us. High-end telemedicine sort of cases to work. We can talk for another hour about that, but let's stop here.
Thank you, Dr. Stephen. I'm quite very much interested about the Department of eHealth presented by Dr. Adnan. So I'm looking, what are the key programs or initiatives of the Department eHealth implemented that can actually serve as a benchmark for other nations, you know, just like Malaysia, in order to enhance their digital health literacy and infrastructure. Dr. Adnan?
Yes, thank you very much. Again, as I presented in my presentation, there is one unique health platform. It is called Health and Norge. This website is used by many people in order to make it sure that they can have their appointments, they can check their vaccinations, they can look at their medicines, and also get useful information about details about how to use this medication. And also they can also schedule appointments with their general practitioners, and also have live chats with the professionals over there. So it's a kind of guidance how to use the system very efficiently. So this is one of the big achievement, I can say. The other one is, for example, developing different type of telemedicine programs for chronic diseases. One of them is cardiovascular, the other one is neurological problems, I can say. And the department is also a kind of department that making sure that the data security is very strict, and they are working very closely with the IT ministry, in short. Of course, there's a long name for this, I can say IT ministry, to make it sure that data security is provided at the highest level. And also the eHealth Directorate are leading different projects regarding developing applications, so people can use it very easily, and also look at their, for example, the wellness status, the steps that they take every day, when to take their medication. So almost the department is touching all households in here for different aspects to keep for health promotion activities, or for following the treatment guidelines very strictly. So it's the department of or Directorate of eHealth is working very closely with the other directly linked organization or indirectly linked organization to make it sure that e-health is efficiently used in this country.
Yeah, I hope that other nations can actually certainly draw an inspiration for such program, yeah, to enhance their own digital health literacy, and it can be a very good benchmark. Yeah, Dr. Zara, there is a growing you discuss about artificial intelligence and the context of the Sweden's universal healthcare system. How does the integration of artificial intelligence and also the digital health tools align with the country's commitment to healthcare equity? And a follow-up question, are there any specific AI-driven initiatives that Sweden has undertaken, especially targeting the underserved or the vulnerable individuals? Dr. Zara?
Yes, a very interesting question, and I have to say that it's complicated. First of all, I'll just address back to the ethical standards that guide the, priorities within the Swedish healthcare. So one of them is related to equity, that the person who needs most treatment should get it, and of course we have the cost effectiveness and we have the solidarity. So that is the basis of our healthcare provision, and it has to be followed. But this has been discussed, at least from my research team. We have been discussing that we don't have the national guidelines how we are going to integrate digital health technologies and AI to ensure that we follow these basic three standards for provision of healthcare. So we are not there yet, I would say. We have a national strategy for e-health, and then we have some kind of a white paper on AI, and there is a lot of investments going on in innovations, new AI. The one which we have, you asked about the examples, we have on precision medicine, and this is mostly within oncology because, the pharmaceutical industry has been there. They have discovered that treatment could see differently on different people. So it's been the oncology treatment which has driven the precision medicine investments, and that is, of course, AI driven.
Oh, very good. Moving to our second theme, I would like to discuss about the ethics, also the equity and inclusivity in the digital health. And Dr. Stephen, according to the WHO, about 30% of the underserved communities have reported feeling of excluded from digital health initiatives. So how can the roadmap of digital health literacy, I saw you have a very good model about the digital health literacy, how can this DHL be adapted to be a more inclusive and address these communities specifically? Dr. Stephen, I think you're muted.
Okay, I'm sorry, I was in mute. I think one of the challenge of developing any digital health technology or literacy program is that people usually, unless you are being funded by government to do so, they adopt a follow the money approach. So therefore, a lot of the uplifting programs are being designed catering for people who can pay. And we know that the Western countries are probably the dominant countries where they can pay for those kind of digital literacy uplifting programs. And as a result, a lot of those kind of programs are being designed particularly for those kind of community. And just to take to do a segue into AI, so we know that AI are being trained. A lot of the AI algorithms are being trained primarily on data that are on the Caucasian ethnic group, and so therefore you have an AI bias against the minority kind of community, and likewise a lot of the digital health uplifting programs and also products are also kind of biased towards that category of a community or consumer. leaving the sort of underserved communities worse off in that way. So that's one of the reasons why I created the framework of the sort of multi-tier framework. The bottom tier actually are the variables that needs to be considered very carefully. Now, taking into considerations the determinants of health, social determinants, and also the culture, and also even the consumer's health belief. Now, all those kind of things impact on a person's readiness to accept the digital health technology, to learn about them and to use them. Now, if any of the uplifting programs are not being designed taking those intersectional variables into consideration, they are doomed to fail. And so, that's one of the reasons when the more I look into the digital health bubble, I shake my head. I say that, look, just looking at that bubble alone is looking at the wrong side of the coin. You need to look at all the other 2 layers that's below the digital health literacy, the framework that I put together. And when you are able at least to address all those intersectionality variables, then and only then you have any hope of improving your digital health literacy uplifting programs are sort of effectiveness and utility.
Yeah, thank you so much, Dr. Stephen. I would like to go back to Dr. Zara, because Dr. Zara, the Sweden have these national quality registries. She also mentioned about that. My question is, how is Sweden addressing the ethical implications of using patient data for artificial intelligence, ensuring that the outcomes do not really advertently exacerbate health inequities? Because nowadays we have really a problem about ethical implications of artificial intelligence. What is your take, Dr. Zara, about this?
Very important question. First of all, when it comes to regulations, which are legally binding, so we have the European Union. So every country within the European Union have to follow those legally binding regulations, regulatory processes. So we have the GDPR, and that's that's crucial, where you have to follow the GDPR. So many actually providers and companies, they've got into trouble because anyone can report you that you haven't used my data that way. But of course, that goes back to the point of what Dr. Chu is talking about, how literate people are about these things. And I liked that you introduced the third dimension of on the literacy, because it's about understanding everything else within your community, the laws and everything, and your rights. I think that's important. So having said that, so we have the GDPR, we have the AI regulations also by European Union. So every country has to abide on that. But when they do that at the European Union, so each country has to integrate that within their national policies. So that's what is going on. But so I said that we also have the digital platforms where all your hospital healthcare documents are in there, even your appointments and everything. So usually you have, when you are going to log into an app, and also you can use it on the computer. So there is a question, do you agree to use your data? And that question is tricky because you don't know how much that data is going to be used. So I think there is more of that. And of course, you see that in all social media platforms and everything, do you agree to use? But you don't know, if you say yes, you don't know if it is going to be that first, it's the first line used, or it's going to be used in a bigger, perspective. So I think those are things that need to be looked at, but data privacy has been driven a lot. And the discussion we have in Sweden, because of all these gadgets we have them at home and all those, and especially when you talk about elderly people. So we have a lot of things that are being used, technologies. So now we are talking about interoperability. How do you connect all those data? But then the next question, who owns the data? So that's the discussion we have, that every person should own your own data. But now we are discussing another bigger discussion on digital platforms, because we don't have a national digital platform whereby you think that I can just log in and get all my data. It's my data. I decide who to share it with. So when we talk about the regulations, the GDPR and the ethical, regulatory processes, then we need to think about the platform, the technological platforms where the data is going to be protected, and who is owning it, and who is accessing it. So I don't think we are there yet, but the discussions are there.
Thank you so much, Dr. Zara, for your insights into the Sweden's approach regarding the importance of an ethical framework in digital health. Dr. Azhar, one of the topics is challenges of digital health literacy for high-risk groups in Malaysian public hospital. Dr. Azhar actually focused into the high-risk groups. I would say these are the vulnerable individuals. What do you think about especially among the minor ethics groups in rural regions? Are there any successful global models that can be integrated in the community feedback in the development phase of, you just mentioned some examples about digital health tools in order to ensure the local relevance and adoption? Dr. Azhar, what do you think?
Right, from my humble literature search or reading, I have not come across any successful application or telehealth solution. But of course, there are some reports of successful projects or good patients outcome per se, right? And like I've mentioned earlier, it may work for cancer patients, but the same tool may not work for cardiac patients, for example. So we need to specifically meet the specific populations. I suppose there are no real success story because it is multifactorial. And as what Dr. Stephen earlier mentioned, the patient factor is something pretty, he used the word notorious, but I would say it's really challenging because in the Malaysian culture, like what Dr. Stephen mentioned, patients still want that doctor-patient relationship, that doctor's personal touch. They still want to come to clinic, they don't mind waiting for hours, right? So this patient factor is something that we would need to tackle and find ways of how to engage them more effectively so that they get into the program or solution as a whole. Yeah.
Thank you, Dr. Azhar. Actually, one of the difficulties also, yes, you have mentioned we all know that Malaysia is a multicultural country, right? So that one also can be one of the possible challenge in addressing this issue. On the third thing, I would like to concentrate on the national strategies, departments, and also economics of the health. I'm quite a little bit surprised actually to learn about the establishment of a dedicated department of e-health in Norway. So it's not something I've come across often. I think Prof. Sarah in Sweden also have this one, but it is not very popular, Can you shed light on how the Department of e-health in Norway was conceptualized? How did they conceptualize it, and how it is inspired by specific events or based on certain research findings? And another follow-up question, sorry, Dr. Adnan, how do you assess then the Department of e-health? Is it really successful?
Yeah. Thank you for this question, because the creation of Directorate of e-health didn't happen in one night. It was a kind of strategic decision, because when we come to year 2000s, what we see in the work that there is a need for coordination of these many different health projects in the country, And also there were also still there were a lot of them, a lot of problems regarding the data security and a lot of technical advancements we face. With the things that were creating a kind of pressure to form a kind of directorate of health to make it sure that it's like we need a centralized body in here and to enhance all digital health initiatives under one hand, ensure that everyone in the country benefits from accessible, efficient, and safe healthcare services. So this is the reason that the Department of eHealth was started to make all these parts of work together, this research and feedback also provided by different research organizations in here and also in the international area. And it is showing that it's a very cost-effective way of delivering healthcare, and also you can reach to many people by using these technological advancements, and also the coordinated body is needed. So to make it sure that patient information is secure, technology is being used for the delivery of healthcare. So there was a kind of centralized body needed, but this body needs to collaborate with the other ministries and also organizations nationally and internationally. So there was a kind of factors nationally and internationally. In summary, coordination need, technological advancements, data security problems, and research and feedback related to technology use are the driving forces for the creation of this agency. The question is about whether it is efficient or not. Yes, it is efficient, because you can see the number of reduced medical errors in this country. And e-prescription is very good because doctors have a chance to see what what this patient is using, and make it sure that there are not side effects when he or she prescribes a new medicine. So he's aware that those kind of things, those kind of chronic or other type of health problems this patient have. And also time-saving activities you can see because of these telemedicine activities. And also some people feel very comfortable when they get their care at home or consultation by using the digital platforms to talk to their GPs. And especially in Corona time, for example, I can give a good example because of this video consultation with the doctors helped a lot of patients to get rid of this COVID problem, and also got good direction and advice what to do if they have multiple chronic diseases, advices from the specialists, from the GPs. Especially in Corona time, we tested the efficiency of the system, how the system was functioning, and also the system was functioning very well. So but if you need more numbers, I can share it later on, but this is an efficient system, I can say.
Yeah. Oh, but I would like to know, I'm quite very interested. You mentioned about COVID-19. During COVID-19, there are a lot of infodemics and miscommunications. How did this Department of Health filter out this fake news and all? Because sometimes, well, I know that Norway have a very good digital health literacy, but do we still have this? I mean, the digital health literacy have the capability to filter out this fake news or misinformation?
Yeah, especially the information. Of course, everything is all information must be an evidence-based, which means depends on the research and also expert opinions. The information provided by the eHealth directorates for the Norwegians in here was very helpful, because it was a kind of first type of problem that people face in their life. So after the Spanish flu, people didn't face this kind of problem before, so they didn't know it. Not only not only patients, but also health professionals use these digital platforms to share information, to get up-to-date information what's going on in the world and in the nation. And also there were some kind of national guidelines when they face guidelines depends on the problem that you have. You can click in and find the information. We didn't feel alone because of these digital platforms, because we were really able to access to many information. If there was a chance or any need, we were having a really good contact with the health professionals to make it sure that we are getting up-to-date information, and if we have any problem, we were sharing our problem and getting some kind of advice to take a journey within the healthcare system of in Norway. So it was widely used, I can say.
All right, thank you so much, Dr. Adnan. Dr. Zara, in some of the recent study from Uppsala University, researchers found that while artificial intelligence solutions in healthcare have really the potential, to drastically reduce manual tasks for clinicians, and however, there's also an observed disparity in its accessibility across the urban and rural regions of Sweden. So how do you perceive then the role of the national policies in bridging this digital divide, and at the same time ensuring that this artificial intelligence can actually contribute to the equity in the healthcare?
Yes, that's such a great question. And I think as Dr. Kisa is talking about, Norway has almost similar partners as Sweden, and Sweden is a long country like this. So we have geographically, it's a big country also, but long and small. So you have people living in the rural areas, whereby the access to clinics is actually a long distance. And now, for instance, winter is starting. When it's a heavy winter, and they usually have very heavy winter with a lot of snow. And what has happened, of course, in terms of population dynamics, that the young people leave, then you have older people staying in the rural areas. So what has been happening? Actually, they have been much more more ambitious in using virtual care, for instance, virtual care, home monitoring. So it's been most what I have seen individual physicians who have been driving this change. And you should know that healthcare in Sweden is managed at regional level, because we have different budgets at local, regional, those will be the regions, municipalities, and then you have the national level. So the national level is more of creating policies, but it's the regional levels that fund healthcare, manage healthcare, and provide healthcare. So they've been active in using these technologies because they can see that they can make sure that their patients can access care much more effectively, but they also save money. And also they have another challenge that they don't have healthcare professionals, because many of healthcare professionals want to work in bigger cities. So there is that challenge too. But in terms of policies, so I think they've been much faster than waiting for the policies, so to make things done. That's my observation. Yeah.
Thank you so much, Dr. Zara. Dr. Hazar, I observe a lot the initiatives and campaigns led by the Ministry of Education and also the Ministry of Health with regards to digital health literacy. So what do you think can be a good collaborative strategies that can be employed so to harmonize these efforts between these two Ministry of Education and Ministry of Health?
That's a good idea. I agree with you. I mean, harmonizing both the Ministry of Education and Ministry of Health would be a good idea, because we all know that education starts at young, and we also know how young people are very savvy with their devices, right? They are more comfortable with devices and navigating the internet and devices. And actually we could leverage on that, right? There are issues that especially in the young, where we could tackle vaping, for example, smoking. We could tackle road safety when riding a motorcycle. We could talk about HPV vaccination for young girls, right? We also touch on substance abuse amongst the teenagers, young adults. So it is a good strategy that probably is something that the government should look at, harmonizing both ministries to leverage on digital health and address the health issues that I mentioned earlier.
And that's the reason why Dr. Azhar, I wanted, if you have some programs in your hospital, then maybe our institution can actually help also, and vice versa. So I think it's a very good, strategy to collaborate, if especially with our younger students, about digital health literacy. Yeah. I would, since we don't have much time, I would like to venture about the World Health Organizations with regards to universal health coverage. Dr. Adnan, since you're experts in economics, how can a digital health economics contribute to the universal health coverage internationally?
Money is important, especially for the country.
Yeah, definitely.
So they always look at the numbers and also look at how, when you use this amount allocated money, how many people's life you can save and reduce the mortality and morbidity in a country. So when we talk about the universal health coverage and also the impact of health economics on universal health coverage, digital platforms, health literacy, this is really a kind of overlapping issues and very important issues. So when we talk about the health economics related to these approaches, what we see, the most important part is the cost cutting. Of course, cost cutting doesn't mean that you are sacrificing the quality of service provision. So this is the important part. Second part is we need to think about reaching more people. So when you reach more people, especially the people live in the rural areas, which means that you are more effective to deliver those services who are in need. This is the second part. The third one is that better healthcare can also be provided, because you cannot employ many specialists in the rural areas, but you can get the consultations from the specialists located in the urban areas by using different telemedicine or digital health techniques to reach many people. And also you save time and resources. This is another part that health economics can make contribution. So because people don't need to move one place to another one, and also you save time and resources, it is very important. And by using these applications, that means you are also preventing illnesses and increasing the health promotion among the population, which means healthy people means healthy workforce, healthy students, and being healthy in all aspects. And the other one is the important part is you need to have a sustainability to provide those digital health-related services, because one time shot is not enough. We have different country experiences. For example, Rwanda, India, Brazil, Estonia. Those are the countries that right now are investing a lot, especially in terms of improving their digital health platforms. But when you think about Rwanda, for example, many people live in rural areas. They cannot go and reach the big cities, so they get their primary level guidance or treatment or diagnosis by using these digital platforms. In Brazil, it is a very big country, so there was also another good project I remember from the literature about India, and this project was focusing on developed people's health IDs for the all people living in India. It is to create a kind of central platform, of course, with high data security. But health economics is important in terms of money, reaching more people, and etc. But the country's economies are very important to provide the sustainability of those systems. So health economics is important from the political view, and also people like to see when you use your money, what you are sacrificing for. They like to see. So when you use the money one time, that means it's over. So you need to reach thousands of people to make sure that you don't see high mortality and morbidity rates among those populations.
Thank you so much, Dr. Adnan. You know, I'm quite very fascinated about all universal healthcare coverage. So yeah, actually, as you have mentioned, it depends on the economy of the countries. Your money really matters. I really wanted to talk about. I mean, I wanted to know more about the epistemic injustice discussed by Dr. Stephen. You mentioned about education alone is not sufficient to combat epistemic injustice. Then how should the digital health literacy framework be redesigned to accommodate more holistic solutions? Dr. Stephen.
Sorry, can you repeat the question? I was sort of distracted by something else. My apology.
You mentioned about the education alone is not really efficient to combat epistemic injustice. Yeah? And how should the digital health literacy then, this framework can be redesigned to accommodate more holistic solutions?
So the framework itself, actually, if you deep dive into the intersectionality layer, you'll find that it actually sort of implicitly identify a number of hurdles or barriers, barriers of digital health literacy. So from the basic of access problem. So if you don't have access, forget about digital health literacy, forget about digital health at all, right? So there is a disparity of access between the haves and the have-nots, what we call the digital divide. So that needs to be addressed, that's beyond any literacy program, if you don't provide access. So if you consider access as part of the literacy uplift program, then that should be considered. So that's the barrier. And then from the other barriers perspectives, you'll be looking at there are trustworthiness issues. Like say, for example, the digital health knowledge, reliability and trustworthiness. So how do we in addition to providing the educational side, looking at providing programs that would allow us to have a very objective and robust kind of a rating system, right? I put it very simply. So in a layman's term, the good, the bad, and the ugly. So if you can have a system that objectively rate those information that's available digitally to people, and say that, look, this is if you want to know anything about diabetes, so these are the category that is trustworthiness. Like when we are doing evidence-based practice, we have different levels of evidences. You say that, look, this is top-level evidence. This is middle-level evidence. By middle-level evidence, you mean that you have to take it with a certain grain of salt, and then the bottom layer, you don't touch it. The ugly layer, then you avoid it at all costs, that kind of thing. So that's that. And then you would have the need to address the cybersecurity and safety concern. So how does government and also the industry put together those kind of protections? So therefore, it then complement the uplifting program. So therefore, people have a sense of safety and say that, look, knowing that these are the things that we can do to prevent myself being fall into the harm of the hackers or things like that. So those are the kind of supplementary to those education program. And then there is when you're looking at the education program design itself, there are a set of principles that you need to consider. Like say, for example, simplicity over complexity. As Albert Einstein say, when you design something, design it as simple as possible or as needed, but no simpler. So make it simple, make it relatable, make it understandable to people, and sort of make it more about person and less about technology. And a lot of the time, I myself make that mistake of forgetting less is actually more. So take an example of when I'm being asked to make a presentation. When I was preparing this slide deck, it started off with 35 slides. And when I look at it, am I stupid in trying to put 35 slides in 30 minutes? So that's certainly not going to work. So I pare it down and adhere to the principle, less is actually more. So you are able to have a lot more ability to communicate a message if you actually can condense it into a degree that makes it meaningful and relatable to people. So, and that's why I'm saying that digital health or health literacy is not just about education, it's not just about technology. There are a whole lot of those implicit variables that the framework itself sort of embedded that needs to be considered.
Thank you so much, Dr. Stephen. Ladies and gentlemen, as we come to close to this enlightening Q&A session, I would like to extend my deepest gratitude to Dr. Stephen Chu, Dr. Adnan Kiza, Dr. Sarah Wamala Anderson, and Dr. Muhammad Ashar. Thank you so much for sharing their invaluable insights and also your experiences with us. And also to our audience, thank you for your attentive participation and for bringing such thoughtful questions to the fore. I'm so sorry that I can accommodate all. But as we conclude, I invite everyone to continue this dialogue outside to this session and with the colleagues, with your peers, or maybe within our respective communities. And together we can able to shape the future of the digital health to be one of its equitable, innovative, and impactful. So thank you so much, everyone, and wishing you a continued success in all your endeavors. Stay safe and healthy, and back to you, Edison. Thank you so much.
Okay, thanks, Dr. Roy. We shall proceed immediately for a group photo session. It kindly all the online participants to on your time for this memorable inaugural first Sustainable Sarawak Webinar Series 2023. Please. And our technical team now is stand by to take a photo of all of the participants, online participants today. Okay, only 3 snap. Yeah.
There is only 45 participants, Eddie, so I think we can push it into one screen.
Okay, and
is everyone online? Okay, I think, is this about it?
yeah. Okay.
Okay, hold on. Okay, stand by. 1, 2, 3. Okay.
Okay, dah.
Then,
Sekejap,
Okay.
another one. Another one. Okay, hold on. Let me just save this one first. See. Hold on. There seems to be a technical glitch. Hold on. Okay, another one. Everybody smile. Okay, done.
Ladies and gentlemen, this marks the end of the Sustainable Sarawak Webinar Series. 1, please stay tuned to our Sustainable Sarawak Webinar Series 2, scheduled to be held on Wednesday, 8 October, 2:30 p.m. to 4:15 p.m. And please help us to improve our webinar by completing the feedback form. You can access the Google form at the chat room.
Thank you very much.
Once again, I would like to thank our distinguished speaker, Dr. Roy, event organizer, event coordinator, and our audience for joining us this afternoon and making it a success. It is my sincere wish that everyone who have attended this webinar will walk away celebrating our unique, different, but respective responsibility toward SDG. Once again, I'm Edison Riket, your MC for this first edition of Sustainable Sarawak Webinar Series, wishing everyone a great evening and morning ahead. Thank you. Bye.
Thank you so much, everyone. Bye.